Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. As always, this is your chance to get your COVID questions answered. Today is Tuesday, September 13th. We are actually on a different channel than normal because City Council was moved for Yom Kippur, so they're using the Mayor's channel to stream that, and we are on the CDPH channel. So if you found us, good job. And if you're finding us after the fact, please do follow CDPH on social. It helps us make sure that if you're particularly interested in health information, you're getting our updates. So we have a guest here. This is Dr. Isaac Ganai. He has been with us, I think this is your second time on Facebook with me. He is currently at the Chicago Department of Public Health as our relatively new medical director for testing and lab-based surveillance. But when he was on previously, he was with CDC. He was an Epidemic Intelligence Service Officer, which is the same training that I did through CDC, really working on outbreaks. And so he is your man for your variant questions, testing-related questions, and we've had lots and lots of those kinds of questions. So I thought, and actually someone requested by name that we bring back the doctor with the English accent. So I'm doing that. So you have more opportunities to answer questions. So welcome, and thank you for being here.
Thank you very much. Yeah, thanks for having me.
I think, why don't we actually go ahead, just very high level, just so folks kind of know what questions to put in. Talk to us a little bit about what is the latest news in variants. We've gotten some questions in about this Mu variant. Is Mu more dangerous than Delta? How do we think about this? I'll let you go ahead and start with that, and then we'll turn back and do some of the data and updates like we typically do, and then we'll get more directly into your questions.
Sure. So maybe let's start with what a variant is itself.
Yep.
So all viruses mutate as they replicate. So a virus, to cause an infection, typically replicates many, many times in an individual, and as it spreads, it replicates in the next person. And each time it replicates, it can introduce these mutations.
Right.
Some of these mutations are good, and they don't really, or they make the virus less effective, less good at causing disease, less good at transmitting between people. Most of them have no effect on how the virus behaves, but some of them might have effect that's concerning to people who work in public health. So some mutations, for example, could make the virus more able to transmit between humans, or more able to cause severe disease.
Yep.
So when you get infected, the more chance of being hospitalized or more chance of needing a ventilator, those kinds of things. And those are kind of worrying signs that public health people look for. And so we scan the environment, try and look for these mutations, and when they're transmitted between kind of generations of the virus, we call them lineages or variants. And these variants can be concerning if they have those characteristics that might make them more able to evade the immune system, for example. Or they might just be interesting if they look like maybe they have a couple of signs that we should keep an eye on. And then we'll obviously monitor those over time. And then there is the possibility that there's a variant of high consequence. So that's one that would be render some of our public health measures less effective, like profoundly less effective.
Like, for example, if the vaccine were not working against it anymore.
Right.
Yeah.
And the good news is there's no variants of high consequence right now.
Yeah.
There are some variants of concern.
And there's never been a variant of high consequence.
Never been a variant of high consequence. So something we watch very closely for, but at the moment there's 4 main variants of concern that we monitor here in the US. And they're named after letters of the Greek alphabet. So they're alpha, beta, gamma, and delta.
Yep.
And the one that's most common right now in the US, actually more than 99% of cases across the US, in Chicago, in Illinois, is Delta. And that's been the case since the summer. And that's probably because Delta can transmit between people much more effectively.
Right.
So it's much better at getting into other humans and then getting into their cells and causing an infection. And because it's so much better at doing that, it can outcompete and really just push all the other lineages and all the other variants out the way. And before Delta, we had Alpha. And Alpha was also more transmissible than the one before that.
Yeah.
So there's these kinds of successive waves of the new, more transmissible variant replacing the last one.
Yeah, and the Alpha, just for folks who may recall, we had this small little surge back in kind of the March, April timeframe. Michigan got hit particularly hard, but we also saw some increase. We were starting to reopen. We paused just a little bit. We're able to get through that without a lot of hospitalizations or deaths. largely because the vaccine was available, different to what we had seen in the two really large waves right at the beginning and then the one in November and December. So that alpha surge that we saw here was in a lot of ways a new, more infectious variant sort of moving through.
And the same with the Delta variant, right?
Yeah.
Like, it's a very, very transmissible variant, but we're still, when we're seeing an increase in cases and an increase in hospitalizations, but nothing like what we saw in 2020.
Right.
And that's really because of the effective vaccinations,
Right.
even against these very transmissible variants. And I know we'll come on to that shortly.
Yeah, exactly. Maybe just quickly on the two other ones. Somebody the other day asked, what are these new, I never heard about these other variants. Like,
Yeah.
and I looked and I saw them and, there's lots of variants out there. Like, talk about those.
Yeah. And there's thousands
Exactly.
of variants. There's every time the virus mutates, it creates a very slightly different version
Yes.
of the virus, and all of those could be considered variants.
Yes.
Now, some of them we mentioned the four concerning ones. We mentioned that there's none of high consequence.
Yep.
But there's this other category, variant of interest, that we
Right.
sort of keep an eye on.
Right.
And those sometimes get the Greek letter names as well.
Yeah.
So at the moment, CDC are not calling the two newest ones, according to WHO, as variants of interest. And there's a couple of reasons why things might be interesting at the global level, but not necessarily as interesting at the national level in the US.
Yep.
But those two are Mu and Lambda.
Yep.
And so they're currently variants of interest, according to the World Health Organization, but not yet according to CDC.
Yeah, and again, just make sure we have this right. So that variant of interest means we've noticed that this could be a variant that could turn out to be concerning from a public health standpoint. It could even, if it got really bad, become a variant of high consequence. They actually will get elevated and dropped depending on how
Yeah.
they behave. And if you see around the world one of these variants emerging, the WHO at the worldwide level will declare a variant of interest or a variant of concern. But then individual countries, depending what you're seeing in your country, will also declare it. So we obviously follow the WHO, what's happening internationally, and then we look to the CDC, who will declare a variant of interest or a variant of concern.
And there's these various groups of experts in viruses, experts in lab sciences, experts in public health, who look at all of this data really routinely and kind of evaluate these things.
Yeah.
The reason that Mu and Lambda are kind of gaining interest, they've both kind of arisen in South America.
Yeah.
One in Colombia in early 2021 and one in Peru in 2020. And they have led to increases in transmission in some of those settings.
Right.
But it's really hard to know what's due to the variant, what's due to different behaviors. So that's why it's just kind of being watched as a variant of interest right now.
Yeah.
There are some mutations, so we can look within the variant at specific mutations,
Yep.
and there are some mutations that are shared with variants of concern,
Right.
which is why another reason people are looking at them and kind of keeping an eye.
So meaning like a change in the spike, right? Or a change,
Yeah.
these very specific, it's not just, the variant. You actually look at the genetic fingerprint, right?
Right.
And you see how is this variant different than the OG, the original? And if we're seeing some changes that we've seen in Delta or we've seen in Alpha, maybe combined with some slightly other changes, right? That's some of what makes it interesting and worth watching.
Exactly, and
Yeah.
there's been studies to look at those specific mutations and figure out maybe what they mean. But it's really, they all interact with each other, so it's hard to predict exactly what one mutation means.
Right.
And that's why it's a variant of interest that's looked at more closely and then examined kind of, and then it will be categorized later.
Yeah.
So Mu and Lambda are both present in the US.
Yep.
They've actually been present for several months. I think here in Chicago, we had a couple of Mu cases in like the springtime, April. And it's kind of telling that we haven't seen it rise massively.
Right.
At the same time, we have seen Delta increase a lot. So, something to watch for sure. But right now, Delta is causing more than 99% of cases here. And even though some of those variants have been in Chicago and in Illinois for some months, and given those facts, it's probably likely that Delta will continue to outcompete those lineages. And so that's the one we're really watching and paying attention to.
Right. All right, great. So that was a good overview. I'm sure you have additional questions, so you can use the hashtag AskDrArwady, although in this case it's also Dr. Ghanai, on either Facebook or Twitter, and we'll get to some more of your questions. Let's take a look, as always, at our dashboard. CHI.gov/COVID- tells you about what is happening every single day here in the city of Chicago. So as we pull this up, you see we're averaging about 433 cases a day, over 400 cases a day in Chicago Chicago keeps us at that high transmission mark, but you can see it is down about 10% from a week ago. And we were just talking, you can see we had these very big peaks right at the very beginning, and then again November, December, January. This smaller peak, that was Alpha, back kind of March, April. And you can see this Delta peak, at least so far, is looking more like March, April. And with more people vaccinated, we would probably expect to continue to see this sort of, hopefully slower rise.
Just a quick note as well on that very first wave.
Yes.
That looks much smaller than it really was.
Right.
Because at that time, if you think back to kind of spring 2020, there wasn't very much testing available. And we were actively saying at that point to make sure that the people who needed it most got the tests, to keep it to people who were being hospitalized.
Yep.
So actually, there were many more people infected during that wave than we know. Whereas now there's good testing available, and we're seeing still a relatively small increase in cases. Something to watch and be very cautious of, but reassuring compared to the 2020
Yeah,
waves.
and I think that's we've talked about that, but I like you bringing that up in this context, because if you look down in the bottom right here at the positivity rate, which is also something we get a lot of questions about, positivity is basically what percentage of the tests that are being done are positive. So right now our positivity is 3.7%. So about, between 3 and 4%, 3 and 4 out of every 100 people getting tested for COVID in Chicago are testing positive. That's good. We want to keep that under 5%. That tells us we're basically doing enough testing in Chicago. But if you look back, again, this is the whole outbreak, and you see, if you look back at the beginning, sort of before July 2020, the cases were low, but the positivity here on the right side was well over 20%. It was 25, 30%. So, like here, I'll hover over this and you can see we were at 29.4, 29, even a 30% there. That 1 in 3 people in Chicago who was getting a COVID test was testing positive. And so we always look together at both the cases and the positivity. We get questions, which is better? You have to look at both of them. Generally, in some parts of the country that have been having a lot of trouble with Delta, especially highly unvaccinated parts of the country, there are also people who don't want to get tested, frankly. And so there are parts that have seen 10, 20, even 30% positivity. And in that case, you're high risk, regardless of what your case numbers are. So yeah, I think that's a good flag to kind of look at those together. And you see on the top middle here, the hospitalizations, we're averaging 23. That's pretty good, actually, compared to hopefully starting to maybe come down. We don't get those in every single day, so the number can bounce around a little bit. But again, our worst time with hospitalization was the very beginning, followed by this bigger peak in November. We saw some peak here when the Alpha came through. We've seen some peak with Delta, but so far doing reasonably well. And deaths were averaging, between 4 and 5 a day. You can see we're doing about 3,200 vaccinations, a lot of testing actually, more than 12,300 tests we're averaging every day now. So that's where we are. Anything else you want to add, just high level to this or to the testing context in particular?
Well, it's less about the testing actually, but one of the things that hits me whenever I look at this dashboard now is that even though we are seeing an increase in cases, which is smaller than the increases in 2020, but even so, we're not seeing the same commensurate increase in deaths.
Right.
And that's what we're really worried about, right?
That's
we really want to stop the severe disease and people dying from COVID. And I think vaccination is the reason for that, breaking that link between infections and deaths.
Exactly.
So, we know vaccines are extraordinarily effective, but they're not 100% perfect at preventing infection. But even if you do get infected and you've been vaccinated, your chance of severe disease and death is really low. And I think that's borne out by the data on the dashboard.
Absolutely. And I think that's been one of the things where we've talked a little bit on Facebook about how differently Delta has hit different parts of the world. And so when it went through India, where there was very little vaccination, really terrible in terms of hospitalizations and deaths. When it went through the UK, a much more vaccinated part of the world, they saw huge increases in cases, but much, much, much lower hospitalizations and deaths. And it really, you're right, it comes down to vaccination at the end of the day. And it's why we put such a lot of attention on trying to get Chicagoans vaccinated, because we have no goal other than, keeping people out of the hospital, keeping them from dying, protecting the healthcare system, and, getting our city through this. All right, I also just want to show a few slides here. Let me just go into slideshow. So first of all, Just to put this in some context, of course, we always say, what are our numbers here in Chicago? What is this? How are we doing in terms of community transmission and risk matrix? That cases per day, we still are considered high transmission here, although it's been decreasing. That's part of why the mask mandate is still in place, and we've gotten some questions about masks and vaccine. We'll get to those if we have time. But you can see our test positivity has been very good. This whole time, we've actually not moved out of a lower risk or a lower transmission risk because we're testing enough. And then our hospital beds, both for non-ICU and ICU, are kind of in this moderate range, this substantial transmission. We're averaging 108 COVID patients in the hospital across all Chicago, in the ICU across all Chicago hospitals right now, and 283 across all Chicago hospitals, COVID patients not in the ICU. And those are not numbers that make us hugely worried. All of these numbers have been in the red zone, like during this outbreak, but certainly one of the things we keep the biggest eye on. Also, update to our travel advisory. Tuesdays are the day we update it. This entire map was orange last week, and I'm happy to say that we do have 2 states, well, technically 1 state, Connecticut, and then DC, Washington, DC, that have now come off the travel advisory. So the rest of the country is still on, but it's nice to see a little bit of progress. Connecticut is one of the most vaccinated areas, and so hopefully we'll continue to see states turn yellow on this map. Reminder that if you are unvaccinated, we're advising against travel to any orange state, and if you are unvaccinated, you should be testing before travel, after travel, and right now even quarantining, even if you have a negative test after travel, and we can answer more questions if you have them. These are just the updates, again, of how the unvaccinated versus fully vaccinated numbers look like in Chicago. So the red line, these are just cases. So the red line is how many Chicagoans are getting diagnosed with COVID who are unvaccinated, and then the blue line is our breakthrough infection. So people who are fully vaccinated but still being diagnosed with COVID. And you can see, both of those have increased with the Delta variant. As you already said, it's not 100% protective, and certainly Delta is so much more transmissible. We've been seeing some more breakthrough infections, but you see the big difference there between unvaccinated and fully vaccinated, and hopefully seeing both of those start to trend down. Where we look at the hospitalization rates, this is even more substantial. This is the COVID hospitalization rate, again, in red, unvaccinated versus blue, fully vaccinated, and then similarly among deaths. I mean, the death rate is very, very low among fully vaccinated Chicagoans, and last week we showed some more specific data about this. CDC said nationally, people about 11 times less likely to die if they are fully vaccinated versus unvaccinated. It's actually even higher than that in Chicago. It's about 15 times. And then there are subgroups, like where we looked at people 55 to 64 who were Black or Latinx here in Chicago. I mean, the rate of death, the risk of death was like 40 to 50 times what it was those who were vaccinated. So those who were unvaccinated in that 50 to 60-ish age group, 40 to 50 times more likely to die than people who were fully vaccinated. We actually were not able to do a comparison for white Chicagoans in that same age group because we've had no COVID deaths in vaccinated white Chicagoans in that age. And so last week, you can look online if you missed the conversation, we broke all that down by race, ethnicity, and by age. But the bottom line is that vaccine is the most important thing, especially if people are older, to keep folks out of the hospital and keep them from dying. Also, some congratulations, some really nice progress in vaccines here. Want to give a big shout out to zip code 60624. That's Austin, East Garfield Park, Humboldt Park, North Lawndale, West Garfield Park. Biggest increase in our first dose vaccine coverage for eligible Chicagoans. Yeah, exactly. For people 12 up since last week. Second week in a row, this was our top zip code. So great job to 60624 and everybody who has been working in that zip code. I also am thrilled to say that we are almost there. 59 of our 60 zip codes have the majority of eligible Chicagoans having gotten at least a first dose. So this week we had 2 zip codes join this list. 60621, that's Englewood, Auburn Gresham, Greater Grand Crossing, Washington Park, and West Englewood, and 60649, Avalon Park, South Chicago, South Shore, Woodlawn. All of this data, you can find it on our regular dashboard if you go to the vaccine tab, but really exciting. And the one zip code to go, 60633, 43. Honestly, it probably is a little more vaccinated than it shows up here. We know there were a lot of people who got vaccinated in Indiana. Some of those might not be showing up. We know there are Cook County residents. So, but we also know there's a high testing positivity. So there actually is COVID. But the bottom line is I am absolutely ecstatic to see really our whole map here be blue for the majority. 50% is not enough, to be clear. That does not protect enough, but it's a critical benchmark, and I'm absolutely ecstatic. 4 weeks ago, we still had 4 zip codes here. So awesome. Huge shout out to everybody working and the folks in those zip codes that are doing the most important thing. Also, we have 38 Chicago zip codes that have reached the important 70% first dose vaccination coverage for eligible residents. So 60609 joined this week. That's Armour Square, Bridgeport, Brighton Park, etc. And we are now up to 13 zip codes that have reached the 80% threshold for eligible Chicagoans to get vaccinated. So we had 3 zip codes hit that this week. 60657, that's Lakeview, Lincoln Park, North Center. 60622, Humboldt Park, Logan Square, etc. And 60639, Austin, Avondale, Belmont, Cragen, Hermosa. So really, really nice to see. I think especially that 60639, that's a zip code we know well from early, a very, very hard hit, a lot of testing work. Huge shout out for being one of the first zip codes to hit that benchmark. So really continuing to make progress. I'm going to actually turn back to you, Isaac, if you don't mind. We got a question in from Faith State on Facebook saying, is there a relationship between breakthrough cases and how long ago you got the vaccine? And I know you wanted to talk a little bit. I asked, I wanted to see what you thought about this question. And there was an article that just came out yesterday. And so maybe I'll hand it over to you if you want to give folks some background about this and then talk through these graphs.
Sure. So the short answer, I think, is that there probably is some difference between when you got vaccinated and when there might be breakthrough infections. It is worth saying, though, that breakthrough infections are still relatively uncommon. We saw those graphs where the people who are unvaccinated have much, much higher rates of disease transmission and infections. And also that when you are fully vaccinated, your breakthrough infection is much, much less likely to be severe. So much less likely to end up in hospitalization and much less likely to end up in death. Yep. So I think those are kind of key things that's worth saying. But that said, there probably is some relationship between when you got vaccinated and the time of the breakthrough infections. Yep. So I'll click onto the next one first, actually. But this is from a study that came out yesterday in The Lancet, which is a really reputable medical journal. Mm-hmm. And it was written, it's a meta-analysis, so it combines the results of many different studies and puts them into one analysis. Mm-hmm. And it was done by scientists from around the world, including the World Health Organization. And they looked at the effectiveness of vaccination across a variety of different kind of parameters. So, and they looked at 2 different outcomes for efficacy. They looked at efficacy of protecting you against any infection, so just testing positive for COVID. And then crucially, they looked at efficacy for severe disease. So that's kind of hospitalization and death. Mm-hmm. And so on the bottom axis, on the horizontal axis here, that's the efficacy against any infection. And on the vertical axis, that's the efficacy against severe disease. And that's the one that we're really interested in, right? Because that's what we want to prevent, people being hospitalized and people dying. And so this vertical axis, we really want to see points up here in this kind of area of the graph. And so just to kind of something up here would be 100% effective against infection and 100% effective against severe disease.
And something of those are studies, actually, right?
These are studies,
this is like the result of a study. So like where it says early 5 in a green dot, that was showing 90%, more or less, right? Protection against any infection along that x-axis on the bottom. And then around, similarly, 90%-ish.
I think even
severe.
higher, like
okay.
95% or something for the people who are early after their vaccination course.
Okay.
And because this was looking at different studies, it's hard to give a specific timeline because they all measured slightly different timelines. Yeah. But certainly earlier had very high protection against any infection.
Any really high protection, looks like more than 90% against any infection and really high protection against severe infection. Mm-hmm.
And then and there's 5 studies that went into that.
Okay.
And so this black dot is this green dot is the estimate, and then there's actually very small confidence intervals that you can see around it. So they're quite precise with that estimate because they've looked at 5 different studies. The same was true later. So first, let's look at the efficacy against any infection. And so this is what this person who asked the question is asking about, right? So later on, so more time since being fully vaccinated, the vaccine efficacy against getting any infection was slightly reduced. Still pretty high, still very good, still like above 80%.
Yep.
But lower than when it was above that 90% early on. But critically, I think the efficacy against severe disease, so there's how high it is, how far up this vertical axis, was pretty unchanged. So we're still looking at 90% or so above 90% for these people who are later in their course.
Yeah.
So that means that people, even if you were vaccinated some time ago, still have really good protection against severe disease, as well as good protection against getting infected in the first place.
Perfect. So I think we'll leave it at that.
Okay.
We'll post the link to this article, and I encourage, as always, to take a look. It actually breaks down by different types of vaccine and different variants rather.
And different types of vaccine.
Different both.
And they show it all together as well. It's a really cool way of analyzing.
Yeah,
it.
maybe let's show the
Sure.
variant one real quick, just to give people a sense of how it works.
Sure. So this is the same kind of graph. So again, we're looking at the vaccine efficacy against just any infection.
Did you get infected along the x-axis, along the bottom? If you're further to the right, higher protection. If you're to the left, not as high protection.
Exactly. And same on the vertical axis. So higher up is good against severe disease. And so I think the two that's most telling to look at, that have the most amounts of data, are alpha and delta. I'll just very quickly comment on beta and gamma. There's less data here because they're less common variants.
Yeah, we haven't seen as many cases.
Right. And we did have a fair bit of gamma in the spring, but it just got outcompeted by delta, and now we're all delta.
And we were worried about that one because you can see the efficacy was not as good. The vaccine was not performing as well, and it got less attention for whatever reason, but we were more worried about it.
Right. And actually, it was just so easily outcompeted by these very transmissible variants of alpha and delta that in the end it wasn't on a population level too concerning.
Right.
But again, the point being here, the efficacy with these variants of concern is less, like delta is less, the vaccine is less effective against delta at preventing any infection than it was against, say, alpha, partly because delta is much more
We're seeing more breakthroughs, basically, with delta than we saw with alpha.
Right. But the severity of those breakthrouls is pretty unchanged, and it's still extraordinarily effective against severe disease.
Yeah.
So key point being, all of the vaccines in use in the US protect against all known variants of SARS-CoV-2, particularly for severe disease.
All right, perfect. So that was a lot of science for you, even though it wasn't a Science Saturday. Thank you for that. These meta-analyses are really the best. People say, how do I know which study to believe, which is the best? These meta-analyses that pull together a whole host of studies that themselves have been peer-reviewed and studied are really the best studies that we have. So thanks for going over that. Sure. All right, let's get into some more of your questions here. All right. So we've got a question here. Gwendolyn Rose on Facebook. My brother-in-law was a breakthrough case in Florida and was able to get Regeneron right away. Can you explain the treatment and its availability in Illinois? So I'll start and then you can chime in. Sure. So Regeneron, if you've not heard of it, is one of the brand names for monoclonal antibodies. Monoclonal antibodies are a treatment that is available very early on if someone has been infected with COVID and they're at really severe risk for getting very sick, getting hospitalized, or even dying from COVID. So somebody who is over 65, somebody who has a lot of underlying conditions, et cetera. We also sometimes, for people who live in very high risk settings, say somebody who works in a nursing home, if we know they've been exposed to COVID and they have not been vaccinated, we will sometimes use these antibodies to try to protect them from getting sick. The idea here is that and that's called post-exposure prophylaxis. Someone has been exposed to COVID and they're very high risk, but they're not vaccinated. In that case, you're sort of trying to replace the antibodies that if you get COVID and recover, or if you get a vaccine, you would already have. And so it's a way if people have not been vaccinated and they're at high risk to have a concern. But also in this case, it sounds like your brother-in-law had a breakthrough case, meaning he was fully vaccinated and then nevertheless developed COVID. I'm guessing he was either older or had underlying conditions. And these monoclonal antibodies, you have to get them as either an IV or a subcutaneous, meaning under the skin treatment, but they can help keep people out of the hospital. So you only give it before people have been admitted to the hospital and only if they're at high risk of progression. But if somebody is able to, is at high risk, getting this can build their own immune response and help keep them from becoming less sick. So it is available here in Illinois. It's part of why we say if you get diagnosed with COVID, please call your doctor so that they can keep an eye on you. And if you're high risk, your primary care doctor is able to actually refer you into one of the infusion centers. Do you want to add to that?
Well, yeah, I guess just to say that the point of this is giving you some of the your immune system, right?
Yes.
Antibodies are part of the immune response. You get antibodies if you're previously infected, you get antibodies if you're vaccinated, and this is just a way of giving you antibodies directly into your bloodstream, basically.
Yep.
And it's, for treatment, good for people who are at high risk of severe disease. And so, high risk of severe disease, sometimes if they're particularly high risk, maybe the physician will refer for that. But the best way to reduce your risk of severe disease is by getting vaccinated and having those antibodies ready from the moment you get infected or exposed to the virus.
Exactly. So, so that is available, including here in Chicago. And if you, particularly if somebody gets COVID and is at high risk for becoming seriously ill, we want you to get medical treatment soon so that if you're a good candidate for getting this treatment, you can get it. It's one of the best things that are available. Okay, so there's a number of comments here and questions. Kofi Boat, for example, on Twitter, I think is responding. There was this, I'm not sure if you saw this, Nicki Minaj, who is a rapper, singer, yesterday had tweeted out saying that she had a cousin in Trinidad who hadn't gotten the vaccine because he had a friend who became impotent, and the wedding got called off. And, I did respond on Twitter just to say that all 3 of the vaccines shown in the U.S. been studied, no impacts on fertility in men or in women. And in fact, there have been good studies for women that if they are vaccinated when they give birth, that the babies actually can pass some immunity on to their children. And so Kofi Boat, sort of, I think, in response to some of this, is saying, hello, can you brief us about other side effects of the COVID-19 vaccines out there? We're seeing a lot reported online. Are they all misinformation? And waiting to hear from you. So I'll start, and if you want to chime. So Kofi, thanks for the question. I think from the very beginning, we've talked a lot about the side effects that can happen when someone is vaccinated. And it really depends on you and your immune system. I got 2 doses of the vaccine. I had virtually no side effects. Some people get the vaccine and can really feel like they have flu-like symptoms. So you can get a fever sometimes. People can get a headache. They can feel fatigued. There's a number of these systems that you just are not feeling well, but those should only last, a couple of days. And if you're interested, we can post, and I could even tweet, like, what are the most common side effects that we've seen. But they're sort of like, I don't feel well for a day or 2. That is really it in terms of the side effects that have been determined to go along with the COVID-19 vaccine. There have not been any determinations for long-term side effects from the vaccine that happen at the population level. So if you're hearing about fertility, if you're hearing about something happening, a year later, if you're hearing about I don't even know. Please have your antenna up around misinformation because, and it's true actually for really all the vaccines, like the previously approved vaccines, where they've had trouble, that usually shows up in the first 6 to 8 weeks. It's not that we see problems with the vaccine sort of years down the line. So that's one of the things that I think about. What else do you want to add to that?
Well, I think it's important to acknowledge that there are some side effects, like
definitely.
you did, and we've discussed it previously, but I had a sore arm for like 2 days probably afterwards, and I was tired the next day.
Yeah.
Still able to work, but I felt it.
Yeah.
And they say younger people have that, so
exactly.
make of that what you will. But the thing that often gets missed, I think, in these conversations is the very real side effects of COVID-19.
Yes.
Like the vaccine is, there are some side effects. You can feel rubbish for a day or so, but you feel a hell of a lot worse when you have COVID-19, particularly if you're unvaccinated.
Right.
And that's in the short term. We're talking short of breath, we're talking difficulty breathing, needing oxygen, needing to go to the hospital, needing to be ventilated,
Yep.
all that kind of thing. But it's also in the long term and long COVID where
Right.
people are symptomatic for months and months afterwards. And we know that the vaccine not only protects you from getting COVID in the first place, becoming symptomatic or severely ill with COVID, but also helps reduce those symptoms of long COVID. And people who are vaccinated have much, much fewer side effects from COVID if they ever do get it, and reduce their risk of COVID. So
Yeah.
I think you've got to compare to the alternative. And the alternative is, in all likelihood, with these very transmissible variants, getting COVID and having very real side effects, potentially for a long time.
Yeah, absolutely. We'll post that CDC study on vaccine and pregnancy because I see there's some questions there. And just to be extremely clear, because there's a follow-up, the vaccine does not give you COVID, but the vaccine also does not give you long COVID, where you are hearing about people having these problems with their taste and their smell, or they're tired for months afterwards. That is from people who were infected with COVID-19 virus. That is not from people who got the vaccine. We have not seen these long-term effects at a population level from people who got the vaccine. So I just wanted to be super clear on that. No.
And quite the opposite, actually. People who are vaccinated, less risk of COVID, and even if they get COVID, much less risk of long COVID.
Exactly.
So really protected.
Exactly. Brandon Christopher Munden on Twitter is asking, are new vaccine formulas being drafted for variants?
Yes. There are lots of vaccine manufacturers who are working on different, slightly tweaking their kind of recipe to be more effective to the currently circulating variants. But as we looked at in that graph, there's still very good protection against severe disease from all circulating variants right now. And the biggest issue that we're seeing with these variants is this increased transmissibility. With Alpha and Delta, they're the ones that win out more than these ones that make the vaccine slightly less effective, for example. So yes, absolutely, scientists are really working on it. But at the moment, still pretty confident that the available vaccines are providing very good protection against the currently circulating variants of concern.
Perfect. And then Canadian Mounted, following up from Twitter, when the Mu variant becomes dominant, how quickly can the current vaccines be tweaked to deal with it, and how effective do you think they'll be?
Well, I'm not 100% confident that the Mu variant is going to become dominant.
Right.
I think I think Delta is very competitive. I think there's absolutely the very real, almost certainty of further evolution. So the virus will continue to mutate. There will be more variants. Possibly something else will become dominant. It might be Mu, it might be Lambda, it might be whatever else the new one is. So I'm not necessarily confident that Mu will become the new dominant strain because of the increased transmissibility probably of Delta. But that said, when there are new lineages and they might have the capacity to evade more of the immune escape than the currently circulating variants of concern, I think one of the exciting things, particularly about this mRNA technology, that's used in the Pfizer and the Moderna vaccines is that they can tweak it very quickly and then hopefully produce new vaccines that target the specific genetic code of that virus. So there is the ability to tweak like that pretty rapidly. I think the difficulty becomes manufacturing large enough volumes for large distribution, getting it to where it needs to be, shipping it at the right storage temperatures, getting the people to administer it. Like that's where a lot of the delay comes. But that's not the current plan or it's not to produce a whole new vaccine just because there's slightly different variants circulating.
Yeah, so I think, by and large, every time there's a new variant, even a variant of interest identified, scientists around the world start testing it against all the existing vaccines. The biggest, as you heard us say, if we were to see a variant where the vaccine truly was not working, you would see that go from a variant of interest to a variant of concern, and then even potentially to a variant of high consequence. And well before that happened, there would have been work to think about, do we need to tweak vaccines? So I agree it would be a big lift, and getting more people vaccinated now has fewer opportunities for the virus to spread and continue to mutate. So that's part of why we're trying to think internationally and not just nationally, where we think about COVID vaccine availability. All right, we're going to try to get through these a few fairly quickly here. Sure. Alexandria Deanne on Facebook says, a friend of mine lost her sense of smell from a COVID infection. Now, months later, she got the vaccine. Her smell has started to come back, but everything smells like garbage, she says. I think it's something called parosmia. Is this common? How long could it last? Any comment you want to make on that?
I'm certainly not the expert on this. I would be surprised if it was the vaccine that was necessarily causing the smell to come back. We do know that people who have symptoms like loss of taste and smell, for some people they fade after months and months, and perhaps that maybe happened around the same time as the vaccine. Certainly not my field of expertise, but we haven't seen people, for example, having a change in their sense of taste or smell after the vaccination.
Right.
So it's just the
more
infection
often with the vaccine, we've seen people who have had a lot of this fatigue and more of the systemic symptoms. Some of them actually get better. It's like you sort of teach your immune system how to fight it off a little bit better is sort of the thought. But interesting question. The smell taste, there's been more investigation into smell than we ever did before because it was such an unusual effect of COVID. Susan Villanosa from Facebook, should we get the flu vaccine now? Yes. You should get the flu vaccine. Everybody over the age of 6 months here in Chicago, anywhere. Anytime from now, sort of before the flu season really kicks off. So it's just starting to be available in Chicago. My clinic, for example, doesn't have it quite yet. The health department will start having our clinics more next month, but we're starting to see some pharmacies and some doctor's office starting to get it in. You only need to get it once, but you do need to get it every year. So you can absolutely go ahead and get your flu vaccine right now or in the next month or two. All right. We are just about out of time. Joanne DeAngelo on Facebook says her husband is returning to the office next week and is worried about the L trains. I take the L to work every single day, and it's the main way I get around the city. I've been very, very pleased by mask compliance on the L. I think there have been a few situations where that was not great, and actually the CTA has stepped up sort of enforcement and masking. That's been more after large events, baseball games, gatherings. But that commute, I think, has been good. People are respectful, they're masked, they're distanced. And I would encourage him to leave some extra time, so in case a train does come and it's really crowded, to be able to wait for the next one. I do that occasionally, and there are many more people taking the trains, but I generally would remind you that where people are masked, and CTA has also done what it's able to, ventilation, they do a lot of cleaning, all the rest of this. Wash your hands after you get off the train, and go ahead and take it to work. But I am very confident, and I've been taking public transportation for months, and I feel safe. But leaving a little more time just in case there were to be a crowded train would be my one recommendation.
The other thing I'd say, I think a lot of people, that's all important advice, and that there can be a risk in crowded settings like that. But a lot of people assume their risk comes from places like that, where they're getting the train into work. But actually, what we see, and when we do case investigations and contact tracing, a lot of the true exposure happens when you're in the lunchroom at work, and it's your buddy, and you take your mask off, and that is somewhere to be really careful. As much as it's also important to be careful on public transit, etc. Yeah,
and thank you for saying that. Yeah, where there were some studies that had been done, having public transportation open or not, you look at this internationally, did not actually have a big impact on COVID. And again, I always go back to, if you are thinking about COVID, where we have seen trouble with COVID is where people let their guard down. Yep. It's why most of the infections have been, most of the transmission at home, right? When of course you have your mask off, you're close. It's the settings where people tend to think a lot about, I'm getting on a train, there's people I don't know. But actually in that setting, people are thinking a lot more about COVID. They tend to keep their mask, they tend to keep the distance. And it is when people let their guard down, especially taking the masks off, especially indoors, that we see some more concern. So, part of why not just Chicago, but it is a federal requirement to be wearing a mask on public transportation. And, Biden just announced they're doubling the fines. They're really trying to double down on this, is that we know in public transportation, you're going to potentially be in closer contact with people you don't know. But rest assured that the things that have gotten us this far have also gotten us that far related to public transit. And CTA is the only one that did not ever shut down. Right. We've kept it going 24/7, and they were running a lot of extra trains. Even when it was not financially as good for them to do this, to make sure that we could keep people distanced, to make sure the buses and the trains, have the masks available. A functioning and safe public transportation system is critical for any functioning city. And there have been lots of people, me included, taking the train to work every day. So I'm glad he's coming back to work. Keep that mask on. In the office too, right? In communal settings. And if you're taking it off especially, think about, can you be distanced? Because that's the most important thing. All right. So we're just about out of time, but we're going to take one final question for you. Nancy Amara on Facebook says, haha, where are tests for the variants? There is no such thing.
Yeah, and I think broadly you're not wrong. Like the tests that you're talking about, maybe when you go to your healthcare provider, when you go to the pharmacy, when you're buying them off the shelf, when you're getting an at-home test, all of those, or going to the hospital or whatever, those kinds of tests are not tests for variants. Those are tests for the virus, and it will detect all known variants. And it won't tell you which one, it'll just say, you have COVID, or you have the virus, SARS-CoV-2, that causes COVID. So that's all the diagnostic tests that are available right now just tell you, do you have the virus or do you not have the virus? The tests for variants are then on those samples that we know have the virus. They have to go to a specialized laboratory. It can only be done on a certain subset that meet specimen criteria. You need a certain volume, you need a certain amount of virus in there. These specialized laboratories then look and do a special kind of analysis called whole genome sequencing.
The genetic fingerprint, basically, of the virus.
And they'll look for those mutations, and then they can say, having looked at that genetic fingerprint, we know this is a Delta, we know this is an Alpha. So CDPH, we partner with, we have a laboratory through Rush University Medical Center that does this. CDC has a system that does this across Illinois, including in Chicago. The Illinois Department of Public Health has a department that does this. Other academic centers like Northwestern have departments that do this. So there are places that do this, and we have good surveillance in Chicago.
And we share all of that data in a way that protects individuals' privacy. But every time this is sequenced all over the world, the scientists are actually uploading those genetic fingerprints to be able to compare, because the whole world needs to know what's happening with variants.
But it's not the kind of result that goes to individuals and says, oh, you've got a Delta, oh, you've got an Alpha. It's not that kind of test. It's on a completely different timeline, so it's not helpful for you in those kinds of...
And you don't treat it differently.
Right.
Yeah.
So it's you're right in that when you go for a test, it's not that kind of a test, but we do perform that kind of testing and have good surveillance in Chicago for the variants.
Yeah, and so the reason you hear us say, when I say there are, 433 cases of COVID, I don't say there were, 392 of Delta and 100, that's not how it works. But we sample, from across the city, from across different settings, and the same thing is done across the US. And then we look and we know at this population level right now, more than 99% of the tests all over Chicago, Illinois, the country are Delta. And so we know, without having to test every individual one, chances are more than 99% that your positive COVID test right now is a Delta variant. And so that is, I hope that helps kind of clear that up. There's always testing questions, but that's a good basic one. So thank you so much, Dr. Isaac Ganai. He is CDPH's medical director for testing and lab-based surveillance. He has spent all of COVID thinking about tests and variants, and is really one of our experts at CDPH. Thank you for your good questions. If we did not have a chance to get to them on Thursday, I will be on actually just by myself, so we'll have some more opportunity to get through some of these quickly. But I think it was well worth it to have some more in-depth conversation about this, because I know it's something you've had questions on. So thanks again for coming. Thank you for tuning in. We will be back Thursday at 11 a.m. normal time. And I think we'll probably be back on the mayor's channel as well, but I guess we'll see. So in the meantime, please be safe. Talk to anybody you know about getting vaccinated, and keep that mask on indoors. Thanks so much.
Thank you.